Welcome everyone, and of course a special welcome to Mari Lundberg, and welcome to this masterclass lecture by Professor Mari Lundberg. Mari is a professor at Sophia Hemmeth University and also affiliated to the University of Gothenburg, and more recently in the last year she also became a visiting professor in our university in Brussels here, and normally the plan was for Mari to be here with us in Brussels today to give her lecture and to enjoy a afternoon session with the colleagues of the Pain in Motion group and to enjoy some drinks and good food and everything. But unfortunately, the rising corona numbers forced us to reschedule all this and make it a pure online event. But still, we're very happy to welcome Mari and to give her lecture on prehabilitation, and her work is focused on prehabilitation in the field of spinal pain, and she has done some very interesting innovative studies on person-centered health promoting prehabilitation. And so I will give the floor to Mari, and afterwards, of course, everyone is free to ask questions and fuel the debate on this very interesting topic.
Thank you, Joe, and thank you for the invitation as well. So, and as you said, I and my PhD student Rickard was looking forward to come to you in Brussels and enjoy life again. But we have to reschedule that, so we look forward to meet with you all later this spring. So I was asked to give a presentation on prehabilitation, and the title was kind of long, so I abbreviated it to make sense. So it's about it's a window of opportunity and a start for a healthy life. I've chosen to call the presentation. So, and I'm sure you all heard of Greta, which is the youngest kind of person here in Sweden who makes her voice heard all over the world. And I will not refer to myself as the next generation of leaders, but as Joe said, I'm a head of the department at Sophia Hemmeth University here in Stockholm. And I'm also a professor, affiliated professor at the Center for Person-Centered Care at University of Gothenburg. And of course, I'm proud to be visiting professor at VUB. And I'm also been a physical therapist now for almost 30 years, and some of you perhaps don't even born yet. I have a PhD in orthopedics, I'm a Bachelor of Science in psychology, and I'm a professor in physical therapy. Since 2015, I run the group Back in Motion, and I have like a motto is I like to move it, and that comes of course both with movement, but also with to move your kind of thoughts. And I have an overall mission with the Back in Motion research group, that is to bring people back to motion, and despite or even when people have pain. So that is kind of the overarching mission with our research group. It is a multidisciplinary and also international research group, which includes people all over the world and with different professions to bring the research further. And today I would like to cover some of the topics given what are the barriers to be healthy for patients who undergo surgery, and can a prehabilitation program be health promoting, and can a prehabilitation program optimize the outcome of elective back surgery, or more, how could a prehabilitation program optimize the outcome? And I'm sure you're all aware of kind of the global burden of low back pain that has been on the agenda for many, many years now. What has not been so highlighted or so evident is that it's a global public health problem. It has been raised already, or known, that it's the one of the conditions with the most years lived with disability for those who suffer from chronic low back pain. But in recent years, we have also highlighted the kind of the secondary effects of having pain is also that you avoid to be active and thereby increase the risk of poor health. And of course, the consequences of low back pain, as I said, it's a leading worldwide cause of years lost to disability. And on the global and social level of society, it loss of productivity, financial loss, and also, of course, the overprescription of opioids. And on the personal side, it's about suffering, and it's also a comorbidity with depression, disability again, loss of identity even, work loss, and even premature death as a consequence of the lack of motion. So in this talk, we will talk, I will focus then on low back pain as one of the pain conditions. And even more so, I would go on the chronic pain, with low back pain as the chronic pain condition. And also now in this talk, we focus on the surgical, those people that undergo surgical procedures. And they are very few in relation to how frequent it is to have low back pain. So only about 0.5% go into surgery, and that, of course, is as always a number that changes. But what I want to say, it's a very small group of all patients that suffer from low back pain undergo surgery. And also, and the major for the surgical candidates are all given the degenerative disease, and the major diagnosis is spinal stenosis, and the age group here in Sweden is 69 years on average. We have disc herniation, in which the patients are on average 44 years old. And then we have the movement-related pain, which is the smallest group, and they are about 46 years of age. And then the ones of you good in maths, the numbers doesn't even up, and there are of course some groups that we don't talk about now with spondylolisthesis, which is another kind of surgery. What kind of struck me and what I took interest in early on is that the complexity of pain has not, or maybe you will object now in 2021, but almost 20 years ago when I started to do research, it was the complexity of pain was not applied in the surgical context. You talked about the people that were kind of depressed. It was more like a criteria not to undergo surgery. And we talked more about, or almost exclusively, of the sensory component of pain. And I wanted to integrate more the broader picture of pain when we talked about patients who will undergo surgery. And that kind of question, like a clinical question, led to research. And I defended my thesis in 2006, which had the focus on kinesiophobia. And I will explain more about the interest in that. This is, of course, another perspective. And I'm sure you will not share these pictures. This is my son, Victor. And I tend to show this picture, not because I'm of course very proud of my son, but that also has to do with a huge improvement in the understanding of pain that has been over these 20 years. When he was born, he did a test in his heel, which they did without any painkillers at all, or they just like took the needle and stuck it into the heel. Some years later, when his sister was born, they did a proper kind of preparation she had to have some sugar first, and then they put the needle in the hand after she had had some pain medication over her hand. So the knowledge of pain has really exploded during the last 20 years. And one thing that I also thought was, when I started doing my research, was that we tend to talk about people or patients with low back pain as a certain kind of mankind. And I also wanted to change that. And I also then in order to understand more about the people behind the diagnosis, we did interview studies, and which also shows the personal burden of low back pain. And this is one patient that could exemplify the results in one of the studies we made. When the pain was worst, I took painkillers and sleeping pills, and I also drank hard liquor in order to sleep at night. Just to get through the night, really. I didn't care if I died or what happened. That was what it was like some days, because I was in so much pain. And maybe you would think this is a patient that is a pain management clinic, but this was a patient waiting in line to get surgery and had not had pain for that long time, had a herniated disc, but all his life kind of fall apart due to that pain. And the goal with elective spinal surgery, which we are talking about here today, is to optimize kind of the pain relief, to have normalized function and health-related quality of life. In Sweden, however, and that is like similar numbers internationally, 1 year after spinal stenosis, 45% are hesitant or dissatisfied with the surgical outcome. 27% are still taking pain medication, and 51% could walk less than 1 kilometer. And the kind of overall question that patients have that come to surgeries, will I be better or worse? In this case, it's after spinal fusion, but it could also go for all kind of spinal surgery. So, and questions I had, and some I still have. How do we best prepare patients for spinal surgery given the complexity of pain? And why don't we apply evidence-based care for patients with chronic pain in those planned for surgery? And why do we not support patients with low back pain to a healthy life in motion before surgery or even after? And what is the best possible way to get people back in motion while in pain? For this, it was a model set up in, this model is with Top and Dietmar, they did actually 2 different publications. And they set up this model in terms of thinking that if we could improve the functional capacity before in the preoperative phase, we will increase the kind of the gap. So given once the surgery is performed, all patients will drop in their capacity, in their functional status. But if you, and the theory is, if you try to improve that kind of gap, that window, you will have a better option to reach a better outcome after surgery. But prehabilitation as such was first mentioned in 1946, and that was actually the British Army who conceived a prehabilitation program for young recruits. Since they lost a lot of recruits in the world wars, they now wanted to recruit and also to train the recruits better. So they were trained in strength training, and it was also, they also had nutritional better food. And 12,000 men went through the program, and 85% improved remarkably, both in functional capacity, but also in their mental health or mental abilities. In the modern prehabilitation, if we look into, there are several kind of systematic reviews and even meta-analysis nowadays. And the prehabilitation is applied in different contexts, in cardiology, before cancer surgery, and in ACL injuries, anterior cruciate ligament injuries, and then also in low back surgery. And the modern, if you look at what are kind of the cornerstones, you will find physical activity and nutrition and some kind of psychological support to reduce anxiety levels before surgery, for instance. But there is also a kind of overall consensus that these studies are low powered. So we need better designed studies with the well-powered studies, and also more And also we can't even say something now about what kind of physical activity and so on and so forth, but that is on its way. And what we know about the modern pain management for chronic pain is that we should do a combination of targeting the psychological factors such as expectations, pain beliefs, catastrophizing fear, depression or depressed moods, in combination with physical activity and exercise. Even so, we don't apply that on a regular basis for patients before spinal surgery. For patients undergoing ACL surgery, that has been the case for years now, that before you undergo ACL injuries, it is clinical practice, here in Scandinavia at least, that you have to undergo prehabilitation before they even take the consideration to do the surgery. So the evidence-based practice for pain management is a combination nowadays of exercise, pain education, and psychological interventions. And that was what we wanted to also to apply in this prehabilitation concept. One thing that also has been strongly promoted, this is a paper by the Lance and Low Back Pain Working Group, they call themselves. It was published in 2018. And what I really like with that paper is that it's a strong focus on health as opposed to disability. Disability has been the primary outcome of low back pain, low back surgery, and still is. That is the major one, the primary outcome in almost all studies. But what Rachel Buchbinder and the co-authors here state is we need to move away from the emphasis on biomedical and fragmented model of care and develop interventions. Moreover, she also says that we need to, this kind of move to more health promoting focus should be for all conditions. So that even goes, of course, for patients that are waiting for surgery. Even more so, we also have the support from the sustainable goals in terms of UN and WHO's recommendations, ways to sustainable health. And it has been evident that a lack of physical activity is a significant risk factor for non-communicable diseases such as stroke, diabetes, and cancer. And of course, that goes for patients with pain as well. And it's even so that the risk for the non-communicable diseases increases with pain, since pain is a barrier to be active and thereby an increased health risk. And we also know, why is movement even like prescribed for pain? As I said, of course, the physical activity is a way to health. We know there are more than 3 million studies on the relationship between physical activity and health. We also know that in relation to pain, physical activity is part of activate our own endogenous pain system, and it is effective towards and first line treatment in terms for depressed moods. And in addition to the kind of the health aspects of being active, it also have this existential component to people, and it gives a meaning to who we are. This is again another quotation from an interview study we made, also on patients with chronic low back pain waiting for to be evaluated at the orthopedic department. And I'm a person who was always busy. I was never still. I was always on the road, and I loved it. When I could not do it any longer, I felt like a second-class person. So these are the implications and consequences for the person, what it means to you. And of course, that is different. That is not the same for everyone. And then Johan Flyen and co-workers brought forward this model to try to understand how come that people don't move, or why do they get stuck in a for them negative behavior. And he introduced then the nowadays well-known aspects of fear of movement, catastrophizing, and later on Vobie added the aspect of self-efficacy. And we also shown that the fear of movement is a barrier to stay active. And we looked into specifically then what is the kind of prevalence of fear of movement in an orthopedic context. And that was part of my thesis when we showed that 70% of the patients who were waiting for surgery had or presented with kinesiophobia. And in another study, we found that 1 year after surgery for patients with herniated discs, the patients with kinesiophobia were also those with the worst outcome. And in a recently published paper, in a longitudinal study over 2 years, we could see that kinesiophobia was related to greater levels of disability following lumbar spine surgery. So we were a group of people that from different professions, from different countries, that sat together and wanted to understand these. How could we put together a prehabilitation program that could address these issues, that could reduce the fear and promote health, and then to stay active despite pain. So what we did, we were a group of, was Hanna Lotzke and Max Jakobsson, PhD students, and Helena Brisby and Ole Hego, who are orthopedic surgeons in Gothenburg, together with Anneli Gutke, who is also a PT in University of Gothenburg, and Rob Schmetz, who is also part of the Pain and Motion Group, a professor in rehabilitation medicine, at that time in Maastricht, and also Marlies den Hollander, who also was in Maastricht, and they also had already good evidence for how to reduce fear of movement, and we wanted to apply it in the orthopedic context. So we went to them and tried to build an intervention together with them. And our prehabilitation was set up in 2 parts. One was about the intervention, another one was about the outcome. As I said, mostly the primary outcome is disability measured by ODI or any other questionnaire. And we wanted to expand that and to bring forward physical capacity measures, measures of physical activity with objective measures, and also with measures that were targeting the patient's own goals. And as I said, in terms of the intervention, it was a collaboration with Maastricht University to build an intervention that will fit into the orthopedic context. That project resulted now in 2 theses and several publications. And the one was person-centered prehabilitation program to improve functioning by Hanna Lotzke, and outcome measures of functioning and physical activity in patients with low back pain, exemplified in patients who undergo lumbar fusion surgery. So those are both theses to look into if you're interested, and I will go through some of the publications. For this particular prehabilitation program, we recruited 118 patients from 3 clinics in Gothenburg, Sweden, between 2014 and 2017. So it took 3 years to recruit this group of patients. And I say that, and I emphasize it because to you, all the people out there doing clinical randomized controlled studies, if you want to do them thoroughly, it usually takes time. And I talked to Wouter the other day about just the thing of recruiting. It's indeed a challenge. And again, so we wanted to do this prehabilitation program and recruited this patient, and the focus was on health. But honestly, there's something that I really regret, and it was that since I was the PI, principal investigator, I am the one to blame, because I was not brave enough to take physical activity or health as a primary outcome. So we choose to have disability as the primary outcome, even though we already at that time said we didn't quite believe in it. So, but what we did in terms of, at that time, when we set up this intervention, there was not so much out there in terms of what do we know about the physical activity level before surgery? There was, of course, this kind of thinking that people with low back pain are kind of disusers, but we didn't have so much data actually. So we did this study with the baseline data for these patients using an accelerometer to measure physical activity. And we found that 83% of the patients included for this study did not reach the VO's recommendations on physical activity. And so many patients might be at risk related to inactivity. We could also see that higher levels of disability and fear of movement were associated with fewer steps per day. Another thing we did was, in terms of the personal thing, the questionnaires are usually set up, they are designed to be reliable and valid on a group level. And that is, of course, good for us researchers, that we could make good research based on valid measures. So what we did in terms of to use personal goals to guide the intervention, we asked the question, what would you like to be able to do that you cannot do because of your pain? And we used the patient-specific functioning scale to follow that. And these are also some of the pictures we used based on, in a feasibility study, what patients addressed as relevant for them. And in a 2-year follow-up that is soon to be published, we could see that in all other outcome measures, the patients kind of, after 6 months, they kind of flattens out. But in terms of this personal goal, it continues to improve over a longer period of time. So it takes longer time for the patients to reach the goals they want to achieve. But what did they do in the intervention? It was set up as a 5 session. It was 4 sessions before surgery and a booster session, one session after surgery. And as you could tell, it is based on the cognitive behavioral thinking that we want to reduce the fear by having the patients challenge their beliefs and thoughts on physical activity, but it was very guided towards the goal they were aiming for. So one part was also an educational session, one was the cognitive behavioral experiment in which they were challenged in their thoughts and beliefs, and it's also very closely guided to a personal goal setting. And at the 6 months follow-up, we could see there was no significant effect on ODI, our primary outcome. What we could see on the secondary outcomes was that the largest between group difference and effect size of 0.57 was on EQ5D, and the major kind of difference was seen 1 week prior to surgery, that is directly after the prehabilitation program. And that effect was carried over until the 6 months, but the largest gap was seen 1 week prior to surgery. And as you might recall, we also were interested in looking at different outcome measures. So Max Jakobsson, who was taking the lead as a PhD student in looking into the outcome measures, he did a very thorough systematic review on the measurement properties of the physical capacity measures that we use to evaluate function in low back pain. I'm not sure now whether there is hello?
Yes.
Okay, do you still hear me?
Yeah, perfect.
Yeah. Okay, sorry, there was something happening. That's why I kind of had the concerns. Okay, thanks. So, and Max did first a systematic review looking into, okay, of all the functional performance tests and physical capacity tasks out there, which one are the most valid to use when we want to evaluate the outcome for patients with low back pain? And what we could find was that there was the 1 minute stair climbing and the 50-foot walk that were both reliable, valid, and also were responsive enough to use. And more so, we could also show in another paper that when we did prediction of, and then we have both physical activity and disability as the outcome, we're testing different regression models, we could see that different factors contributed to the outcome. And you would say, yeah, and what else is new? And what we wanted to show with this paper is that physical activity and disability are different constructs, and factors such as fear, catastrophizing, physical activity, they contribute differently to the outcomes. So if we want to achieve better physical activity, we need to address some factors. Are we interested in reducing disability? There are other factors contributing to that. So, and how we have now moved further into this is we have continued with a Get Back, which we recently got funding from the Swedish Research Council to continue our project. And we want even stronger to go into the health promoting prehabilitation line of this research. And we also, what we want to do is to add, so we want to optimize the outcome even more by screening for the patient with the greatest risk of poor health. And that is, we discussed it just yesterday, how to pick out those patients based on both a combination of psychological factors and the physical capacity, so that we will have increased the likelihood of a good outcome in terms of health. And this is Rikard Hanafi, who is the PhD student. And as always, we work in team. These are kind of my favorite team, but there are other teams. And if you would be interested to join our team, we are now just to send out an application for, we're searching for a postdoc to join our team. So if you would be interested, just have to reach out to me and I will address your application. Yeah, and of course, I want to acknowledge the funders for this research. The Swedish Research Council offer research funding and Eurospine research grants, among others. So thank you. I know we'll leave time for questions and discussions.
Thanks a lot, Mari. That was very clear, highly informative. And yes, it's good to open the floor for questions. And of course, questions can be asked by putting on your microphone and your camera and just ask the question straight away to Mari. But in case you prefer to post your question in the chat, that's also a possibility. And we'll follow the chat to facilitate that. Perhaps, Mari, it's best to stop sharing your screen, then we can have everyone as good as possible in the screen available. So, questions from the audience.
I just have to stop my screen.
Yes, if you choose the cross just to the left of the red button. No, on the left of the red button.
So now it's right, or?
No. That's the one, yeah, that's the one. That's
yeah.
The one.
So please feel free. The discussion is the good part with presentations.
Absolutely.
That is where you learn the most.
Well, maybe I have a question, Mary.
Great.
Thank you very much for your very interesting presentation, and it's amazing to see the work that you have done during all these years. I was just wondering, because you definitely pointed out that recruitment was one of the hardest stuff in your study. Do you had some, of course, context related in your type of population, facilitators and barriers that you could overcome, and like a golden something that in your study make the difference, that really made that it was successful for the recruitment that you wanted to have?
Of course, you need to have grit, you need to be sustainable yourself. But I would say the main thing is, of course, to make sure you have the right gatekeepers. You need to collaborate with, you need to have the surgeons on board. You, as we all, what we know about implementation, that you need to have the kind of the ones responsible need to say, yes, this is something we should prioritize. Otherwise, it will be harder. Then, of course, to have a gatekeeper, and by that I mean an internal person that is into the clinic or site that you have, and you also should have a kind of a project coordinator on site, a site coordinator that really hunt high and low and you need to be kind of a pain in the ass to continue. And also, as you said something really important, but it has to do with the context. So you can't come as a researcher and say, this is what we would like to do. You have to understand what works best. In what way could we get this done with as little effort as possible for the clinicians, because time is their kind of value. So make it as simple as possible for them to participate. Ask them, what would be the easiest way for us? And then you are the one who has to do the work. And for us, it was like, might sound, but we had like colored papers that were kind of put into the patient charts, which was like a sign, this is the study. And even after that, the study coordinator called after every kind of day or went through the charts to see that we didn't miss a patient.
Interesting. Okay, thank you.
So it is a really lot of practical issues, and to be involved and engaged in the clinical site as such.
Thank you very much for the the tips. I don't know if I had a second question, but I don't know if someone else or something different on another topic. I was thinking about the pre-rehab program. Did you had also some patients that by participating in your pre-rehab program decided to cancel the operation, and just that was on itself a health increase and a promote? I mean, I don't know how you dealt with that in your study, because you had also a part after the surgery, but was it as also seen as a success in that sense that the number of surgery would then be reduced?
And you're absolutely right. We just had a few, but that is something I think we had, I don't remember on top of my head, but I think it was 5 or 6 patients. But that is something that we discussed should be built into the process, and also to give the patients the opportunity, like in after rehabilitation, to thereafter to say yes or no. That would be
to make their own decision. Yeah.
Yes, and also build in like the decisional process is that rehabilitation is part of that process. That would make more sense. You're absolutely right. That could be something that we also like to bring further. But I could also say that I collaborate with Christine Archer in the US, and she said that rehabilitation in the US is complicated due to the financial system, or that if people don't get what they want, if you say that now you're going to have surgery, but first you're going to do a rehabilitation program, people go across the street to another center, because the expectations of the patients is that surgery will kind of solve the problem. So that is an educational issue, like on the society level, and not only for healthcare staff.
Thank you. Interesting to hear.
Yeah, thank you for your questions.
Interesting discussion indeed. Other questions? I have a few questions, but of course I'll give the opportunity first to anyone else. If not, in the meantime, perhaps, Mari, you can give a little bit more background information or experience in terms of using the, I think it was exposure-like behavioral experiments that you did as part of the prehabilitation approach, which I think it's a highly innovative and great idea. Of course, you need probably enough time, of course, before surgery to actually do that, but can you give us a little bit more information on how that turned out to be?
Yes, absolutely. And that was really, we did a very thorough process. So when we went, as you said, as I said briefly, or that we went to Maastricht, you had a successful program, exposure in vivo treatment, and their protocol at that time, I think it was 18 sessions, if I recall correctly, to kind of reach a successful treatment. So the kind of task we had was to break it down into a brief intervention and what kind of were the core things that we could address preoperatively in such brief sessions. So what we did was we did this kind of pilot or feasibility study, trying to see, okay, if we want to break that down, is that even feasible? Will we even get a change? So, and the first thing we acknowledged was that the difference between the protocol in Maastricht and our protocol was the context. We applied it in an orthopedic setting, and also in terms of in the protocol in Maastricht was set up for the kind of the tertiary kind of the pain management clinic, like the last phase where people have like gone through all the stuff, and this is what kind of the last station in a way. And in this session, people thought that their expectation was the surgery will heal them, or so they couldn't. The way of pain education, I'm sure you're aware of that, in terms of also priming the patient for the understanding of pain and going through to work with the thoughts and beliefs and so on, was of course a barrier that they thought that, but I'm having the surgery. Why should that be helping me now? So we kind of, after that, so we didn't have, from the beginning, we wanted to have an exposure in vivo treatment, but after the feasibility, we changed it more into even more so on the focus on staying active and the physical activity and the health, the value of being active, because that was also a way that we could tell the patients were more prone to take into their understanding. And also we realized that in the kind of small feasibility study, not all of them were even had kinesiophobia, or that were like was so had that to that extent that exposure would be the evidence-based treatment. So the study we do now, we will screen for, they will be included based on the fear component, which we didn't do at that time. Was that answer enough, or?
Yeah, absolutely. Yeah, and I was about to interrupt this in terms of saying, okay, that's probably why you then took the next step towards focusing on the high risk group, but that's what you already explained as well. So that's very clear. Thanks a lot, Mari, and also thanks a lot for being so supportive for the PhD work by Wouter van Bogaert, who's also involved in targeting that high risk group before spinal surgery. So that's highly appreciated. Any other question from the audience? Also, of course, there are several people from outside the Pain Emotion group who are live participating in this online lecture, so feel free to ask your question. There's a question from Eva Huismans in the chat. How do you feel about implementation of the prehabilitation in clinical practice? Have you experienced any barriers for facilitators regarding implementation, or just general thoughts on it? Potential barrier in Belgium, for example, there is at this moment only a time frame available of 2 weeks on average for elective back surgery.
Yeah, and that's absolutely, thanks Eva, and that has changed since we started to do the intervention in 2014 when we started. Then was not in Sweden at that time, it was, I think the waiting time we had, I think it was 3 months or something, that we had like that kind of a window. But now it is the same here at, I think here in Stockholm is 4 weeks, that the average before elective back surgeries. And as you said, the various facilitators, what I so far have, it's a slow process, but you could slowly change. It's to collaborate with the orthopedic surgeons and the show with research and arguments and why you build that into the model. But then of course our system here in Sweden, known to be the most socialistic system in the world, had changed into more of a economic system which is driven by the gains you get in financial ways, which also steers that you can't say that I would like to have 8 weeks because then they aren't paid. So that is a problem, and that problem was already, as I said, achieved or like acknowledged by Christine Archer in the US. So they don't do prehabilitation studies; they do early mobilizations or early rehabilitation studies, as they do in Denmark with Nana Rolving and Heidi Tegner are doing such studies, just completed it. So I think that is also what, of course, you have to, what can you do? You have to work with the time you have, but it is frustrating that the financial decisions are not based on evidence-based knowledge. It's based on money, or I don't know.
Very clear. Thank you, Mari. Other questions from those attending the lecture live? Walter, your microphone is still muted.
Oh, sorry. Yeah, the question also regarding the pain education, where you explained that where you want to educate the patient regarding the expectations of the treatment, especially the surgery. Do you only had to educate the patient, but also the surgery to get them involved in the project? Because you said that most of the main treatment goals is to get the function and pain reduction. And I also assume that a lot of the surgery, the orthopedics might not only focus on the fear and depression and things like that.
Yeah, and thanks for the question, and I totally understand what you're aiming at. And I would like to start out with saying, when I did my PhD within the orthopedic department, I was like then I was looked strange upon. I was interested in psychological factors, and I wanted to do qualitative research. It was really strange. That was in the beginning or late 1990s, but that has totally changed. And not that I have changed it, but what I want to kind of say in a positive way is that things can be changed. And I think the best way to change is to be within the community, to be at the orthopedic department, for instance, to be, and also, and of course, another thing is to show by research. So by gradually showing that, yeah, it is kinesiophobia is prevalent in this population. Yes, they are less physically active before surgery. We need to do something differently. That is also arguments that works. So now I don't have like the same trouble to get into, like, you know, to collaborate, to get the surgeons on board, to be part of the project, and And they will then be the gatekeepers and the facilitators to spread the word. They will open the doors where you can get in and continue to work. So even though sometimes it seems a slow process, it can be done, even though it doesn't as quick as we want to. And for an example, I can say when we talked about physical activity as part of the intervention from the beginning, the orthopedic surgeons really wondered, what do you mean by that? What do you exactly want us to do? And how could that be of relevance for the surgery? And if you look at that perspective, that has really changed throughout the years.
Thank you.
Yeah, you're welcome.
There's two questions also posted in the chat. First one from Celine. What do you think is needed to change the financial economic driven system? And of course, it's partly addressed already in your previous answer, I guess.
Yes, but I have a strong belief in research or science. I think that even though it's not as strong and as quick as we want it to be, I also want us researchers to take part. I took part in a discussion last year, I think it was, or maybe the year before that. The Corona deer just disappeared, in a political session about prehabilitation. We invited a politician to participate in a research session, and she said yes. And I also think that is the way to help the politicians with the right arguments and be out there in all kind of opportunities you have, or make the opportunity yourself to tell them who are responsible for the money. And also a very, very strong force are of course patients and what do you say, medborgare, the people in society. They are the strong forces. If you have a politician who have had a bad back or whatever, use all these sources. And also as a researcher, take part in society. Don't stay just within academia.
Those are very nice and encouraging ideas to take on this important task. Thank you for that. Jeroen asks you, how did you teach the multidisciplinary team to send the same healthy messages to the patients? That's also a highly relevant question.
It's a highly relevant question. And I remember when Eva Husmein and I talked about this in terms of our results, given your results in a similar study, that I think what I'm blind for is that we in Sweden have a more active mobilization already. And that was also shown in a study we made looking at spinal surgeons in the Netherlands as compared to Sweden. And we wanted them to give what they thought about advice after spinal fusion. And we could tell then that the Swedish surgeons were more keen to say that they could be active earlier than surgeons in the Netherlands. So by saying that, I think that on average in Sweden, we already have an implemented kind of active mobilization, which I think I'm blind to that. So I would need someone coming and show that more properly. That is one thing, of course. And that is also one thing we thought that was part of why we didn't get the difference between such a difference between the usual care and our active intervention, was that we think that our usual care got a more active intervention than when we look at these numbers. But I can't say we didn't teach the multidisciplinary team to send the same healthy messages to the patients. So that is of course one thing that could be done, that you follow that more thoroughly also, and how that is given. I think that's a good idea.
Excellent. Thanks a lot, Mary. I think we slowly need to close this session. And I think you did exceptionally well. It was really inspiring to listen to your lecture. And like you said also, you said that the best part would be the discussion. I think it was a very inspiring discussion. But I wouldn't say it wasn't even better than your lecture. I think both were really, really nice. And in particular, because of course I know originally the plan, like we said in the beginning, was for you to fly into Brussels. And this, of course, was our way to buy you to come into Brussels to say, okay, we'll enjoy a bottle of champagne. And
I know. What about the champagne now? That's what I wondered.
But the good thing is, and that's also interesting for the people of the group, is that we secured a date in the spring for you to fly in together with Richard to visit us in Brussels. So we'll update everyone later about the days where you will be actually coming to Brussels to enjoy the champagne and the chocolate and the good food. So
yeah. That's very good. We don't have that in Sweden. Okay. It's all ice bears and I don't know. But please stay in touch if you like. Just send me an email and I will be happy to continue to respond to any questions if I can help.
Excellent. Great.
And thanks again for having me and keep up the good work.
Thank you, Mary. And I'll finish up with a little bit publicity of what I've posted in the chat, that we have secured Dr. Jackie Clark to also give a Pain in Motion online masterclass, just like Mary just did. And we have a date for that. It will be Tuesday, 29th March. It will be a morning lecture, also streamed online. Of course, it will be in the morning because of the time difference, the massive time difference between Brussels and New Zealand, obviously. So that will be 9 o'clock in the evening for Jackie. That will be manageable for her to combine it with her work in her clinical practice and her family life. So that's what we agreed with her. And of course, she will be presenting her work on personality, sensory profiling, anxiety, and central sensitization in people with chronic pain. So this way you can already block it in your agenda 29 March at 9 AM in the morning. And it also will be a 1-hour lecture, including discussion time. So thanks everyone, and have a nice day, and
bye-bye.
See you next time.